All right. Good afternoon, everyone. And thank you for joining us for the fifth and final session of our 2023 Older Adults and Opioids webinar series, hosted by the Finger Lakes Geriatric Education Center. We are a HRSA-funded geriatric workforce enhancement program at the University of Rochester in Rochester, New York, and our co-sponsor, the Western New York Rural Area Health Education Center, also a HRSA-funded education center. My name is Laura Robinson, and I am the program coordinator for the FLGEC. My co-host is Christine Chappell. She is the administrative coordinator at the Western New York Rural AHEC, and we are so glad you can join us for our third year of hosting this series. We have just one housekeeping item for you. So please use the chat button to type hello and introduce yourself with a name, job title, agency, location. We have people from across the country and maybe the world joining us today if Sylvia, our fan from South Africa, is with us. So we are welcoming viewers from across New York State, North Dakota, Tennessee, Oklahoma, Indiana, California, and maybe South Africa. So again, please introduce yourself, especially if your Zoom name does not match your real name. I can only provide CME and social work credits to people with real names. Okay. So now let me go through these disclosure slides that you see on your screen. We have nothing to disclose, not our speaker, not our planning committee. You can see the learning objectives on the screen. We do offer CME and social work credits for this course. After the course, I will send you the link to our CME tracker site. It is a portal. If you've never been in it before, I will also include instructions on how to claim your credits. If you log in before July 14th, you might not see your credits there. The CEL office asks that we allow them 30 days to upload, but they're usually much quicker than that. So if you have any problems getting your CME or social work credits, just send me an email. And no commercial funding was received for this program today. So now I'm going to stop sharing and I will invite Christine to share the slides for today's speaker while I introduce her. And our featured speaker today is Charlotte Crawford, and she is the retired Chief Executive Officer of the Lake Plains Community Care Network. And she recently retired and is very much enjoying retired life. She had joined Lake Plains in November of 2000 as a care management developer and became the executive director in April of 2006. Her responsibilities over the years have included grant submissions and oversight, creating partnerships and chronic disease initiatives for the Orleans, Genesee, and Wyoming counties. In 2007, she led the initiative for the LPCCN to become the Big Lakes Emergency Medical Services Program Agency. And this program initiative focused on assisting emergency medical services in Niagara, Orleans, and Genesee counties, meeting New York State requirements, providing education and other services identified by the Big Lakes and the EMS agencies in that region. Charlotte has always been involved in healthcare, serving as a nurse in various capacities and as a paramedic for 43 years. Charlotte has been an educator in both volunteer and professional environments, and now in retirement, she volunteers at her local fire department and in her church's clothing closet. In addition, she will continue to teach Narcan classes, CPR and first aid, and other topics as requested. She is hoping that these efforts will help keep her from being bored. So we are very glad to have Charlotte with us today. And now I will turn the program over to her.
Good afternoon. I am really happy to see so many people on today. The opioid overdose prevention training. Next, please. I don't have control of this, so I have to tell Christine, poor person, to next. So that's why I'll be saying next a lot. As she said, I'm a nurse and I'm a paramedic. I've been doing this class from, I believe it started in 2015, 2016. Next. What we're going to do, along with the other learning objectives that were already mentioned, we're also going to learn the signs and symptoms of an opioid overdose, which is one of the objectives. The Good Samaritan Law as it pertains to an opioid overdose. How to use Narcan to reverse an overdose, and the reporting that we do in our area. The one thing I want to tell you primarily is these slides are based from mostly Genesee County, because we have a Genesee County Opioid Task Force that I'm part of. So the data and stuff that I'm getting primarily includes there, especially the newer data. Next, please. The nice thing about this program is it allows anybody in the community to treat an overdose with Narcan. I have trained children as young as 12 to do that because there was a need within their family. This program is funded from a New York State Department of Health AIDS Institute money. And that's who gives me my Narcan that I provide at my classes that I train. Next, please. This actually took effect in April of 2006, which was great. But I will tell you, it didn't get into our area until about 2015. And at that point, it was difficult because it was injectable only. And as far as this was great for non-medical people, but EMS couldn't do anything with it other than a paramedic. Paramedics were the only ones that could treat with Narcan for an overdose in the field. You could get non-medical people trained, but a lot of non-medical people wanted nothing to do with injections. So it wasn't as widely spread as it became later. Next, please. Biggest problem with opioid overdoses, and it's not really a problem, it's a good thing, that most of them are witnessed. Usually there's somebody with the person who's overdosing. But sometimes the people that are there with them have a huge fear of calling 911 because maybe they have issues with law, whether it's probation, parole, or other issues going on. So they don't call. But what I've trained people that are on probation and parole, and I've told them, if you're with somebody who overdoses, it doesn't mean you're doing anything wrong. But if you have Narcan available, administer it, lay them on their side, leave the empty Narcan container there, call 911 and beat feet if you have to, but do something. But always call, even if you have nothing, call and go, but lay them on their side so they don't aspirate. People have told me they've tried things that don't work. I had one person tell me they tried having them walk it off. Doesn't work real well. I had somebody else tell me they would dunk their head in water. That really is not effective. So they do crazy things thinking it'll work. But the worst thing they can do is actually leave somebody without doing anything or calling for help. Next, please. This epidemic continues, and was getting a little better, and then COVID put a kibosh on so many things and really was detrimental for people with substance use disorders that were going in person to do different, receive care that way. It's not as effective if they have to do a phone call or a Zoom meeting or something like that. Some of them lack the capability and capacity to do that. So that caused a huge problem. Things started increasing again because they weren't able to do what they were doing in person. The problem with this is the complication from using an opioid is respiratory depression. If respiratory depression occurs because most of us, normal breathing, we are stimulated by carbon dioxide. They get the depression, they don't breathe so well. Carbon dioxide does not get them to breathe, so they can become hypoxic and have brain injury or die if they don't get reversed quick enough. Narcan is a wonderful medication. It is reversible. It helps. It's a great opioid antagonist, and it really saves lives. Next, please. If you look at this, anybody can be impacted by an opioid overdose. You can't classify anybody. I know back 25 years ago, people used to say, oh, the junkies. That's not true, and never wasn't even true then. It was somebody with a substance use disorder. We've come a long way with the way we label people or term their disorder or disease, actually. But you can see people who get pain medications prescribed for them, young people experimenting, and long-term drug users that have been in abstinence and been in rehab or whatever and been doing great. And then they have well-intentioned friends who say, hey, one more time for old time's sake. Which is really horrible because their body is not used to what they were doing and they do what they did before and they overdose again. Happens everywhere. There was a reported case, won't mention where, of a young lady, good student in school, went to school one day and she was really tired. The teacher didn't worry too much about it because she's a straight A student. Her desk was next to the windows. She put her head down and dozed off. The bell rang in the school and she didn't wake up. She was dead. She'd overdosed. So you can't say it's only people that have problems. There's different causes, there's different reasons. But if you have a substance use disorder, you need help. Next, please. Now, you're going to see this is kind of older data, but the things I want to point out, they started collecting data in 2010. 2017, you'll see that Genesee County did an amazing job, and we really did great with 21 deaths in 2017. Not something you want to brag about. Next, please. But if you put it on a level playing field of deaths per 100,000, you see we had 36.2 in Genesee County. You can see them for Wyoming and Orleans as well. But the problem with that is 36.2 made us more deaths per 100,000 than Erie or Monroe County, our two closest neighbors. Not the kind of statistics you want to have. However, the positive is that, next please, is you had people that wanted to do more to help prevent that happening. So you have the overdose fatalities in 2020 and 2022. And this is just Genesee County. And I apologize for that. That's the only ones we have locally. That's the ones.
It's nice to be appreciated.
Nice to be appreciated. Okay, anyways, they have, you can see the female male broke down for the deaths in 2020 and 2022. And this is determined by the coroner, medical examiners rather, I'm sorry. Next, please. We know Narcan was being administered. You can see in 2017, Genesee County was doing, and I'm going to tell you, here's the bad part about this data is it's only as good as the people that were reporting it. And we weren't getting the true reports for all the administrations. We never got reports from anybody who was, I call them John Q. We were getting reports from fire departments and law enforcement only. And this was paper reports that we received. So you can see in 2018, there was only 100 Narcan administrations in Genesee County, 47 in Orleans and 17 in Wyoming, but I can guarantee you there was a lot more than that, but that was only the data that we were given. Again, data is only good as the people providing the information to formulate the data. Next, please. Now, this is kind of a skewed screen because it's all overdoses. It's not just opioid overdoses. But it just gives you a little bit of an idea how many overdoses show up in the emergency room. Next, please. Okay, we have one hospital in Genesee County. And this is characteristics of drug overdoses transported to that facility from October 1st, 2021 to September 2022. Breaks it down by age, male and female. The biggest, we have one zip code that has the largest population. That's in the Batavia zip code. That's the 14020. And because sheer density, they have the higher number of overdoses. Next, please. Now, we're looking at more characteristics, more breakdown and demographics for this. You can see the breakdown, and this is 2022, OD mapping. I don't know if you guys are familiar with that. OD mapping is what law enforcement has where they can electronically report overdoses that they go to. But I'm going to tell you again, it's only as good as the people that actually complete that. We all know law enforcement is busy, and sometimes they don't get a chance to do that. But this is what we've got from 2022. And I'm going to tell you the numbers are low. That's absolutely low. But that's because OD mapping. And the other problem with that is state troopers tend to go on these calls as well, and they don't report it. So the numbers are skewed, but these are the best numbers we have in Genesee County. Next, please. Okay, these are people that completed training. And you can see 2017, we had all those fatalities. 2018, our numbers increased as people that received training. It's kind of sad that we have to do things reactively rather than proactively, which we're trying to do more of at this point. Next, please. I don't know if you're familiar with the I-STOP law, but I-STOP took effect in 2013. And what it did was require all physicians to do electronics prescribing, most importantly, for any kind of controlled substances. The beauty of this is if it didn't make a difference where you went for your controlled substance, they would have to check that system to see if you've received it recently. Having worked in a primary care office, I know if somebody called and said, we need an updated script, I'd have to go into that system and look to see when they could get that renewed. This is what happens. Somebody comes, and it used to, I should say, because I worked in the ER for many years, we would have somebody come from Wyoming County. We'd have people come from Erie County, come to our ER complaining of pain and asking for specific medications. And because we had no way to double check, they would say, well, we're camping in this area and my meds fell in the toilet, something like that. And then you're like, oh no, you really need your meds. You write them a script and you'd go off their merry way. Prior to I-STOP, we would actually do things like only three days prescription or a limited amount. But this system did wonderful things as far as stopping doc shopping. Next, please. You can see this picture shows only people that were getting the prescriptions from 5 or more doctors and going to 5 or more pharmacies. So look at the dramatic decrease once it was implemented. The good thing, bad thing about this is they weren't doc shopping anymore, and now they were street shopping. So that caused an increase in those overdoses. Next, please. There are a lot of things that are opioids. Don't care. I'm going to tell you, I've had people come to my classes and start writing down all the names of these drugs. And I said, don't care. We're not treating the drugs. We're treating the symptoms. So we don't care what they took. People will lie to you if you say, did you take any medications? And they'll say, no, I didn't take anything. They didn't take anything. So don't treat the medications. You're treating the symptoms. Next, please. Okay, when somebody has an overdose, it tends to, and I'm talking more of a heroin or a prescribed medication, it takes 1 to 3 hours. It's a slow onset. Since they've started having fentanyl and other medications like that, they will happen much more quickly. And those are when you get the needle in the arm issues. And I will tell you, after having collected a lot of data, the quick reversals tend to happen with the ones that are taking a slower onset. If somebody has a needle in the arm issue, then chances are they're dead when they get there. But it does happen. And I'm sorry, I'm getting a delivery to my house right now. I hope they don't ring the bell. Oh, good. I'm sorry. Anyways, they say 15% with the addition of fentanyl. That number's going up because they're putting more and more stronger drugs in the mixture of the heroin. And some of them aren't using heroin anymore. It's going straight fentanyl. The problem is the opioids decrease. And I pound this into people's heads. Opioids decrease the desire to breathe. The carbon dioxide builds up, respiratory depression, and they die. You have to stop. You have to work quickly to hit them with the Narcan so they can stop the cycle. Next, please. These are the kind of things you may see if it's a slow progression. Initially, they'll be still arousable. You can wake them up, you can shake them, and they'll respond a little bit. They may be snoring, and that's because sometimes their airway is getting a little more obstructed, and they may drool because they can't maintain their airway well. Overdose, when they finally hit that point, they're not responsive anymore. The breathing may be very shallow, or they may have gurgling again because they're not able to maintain their airway very well. When their skin starts changing colors, and it's not really blue lips, it's kind of a dusky colored lips and nail bed, you really got to do something quickly or they'll die. Next, please. So again, different ways to look at how things go. Opioids repress the urge to breathe, so the breathing slows, carbon dioxide builds up, breathing stops, then oxygen levels decrease even further, lack of oxygen causes brain damage. This all takes time, but if you don't do something to stop that continual downhill, the heart will stop and they will die. Next, please. Narcan is great. It's an antagonist which reverses the opioid overdose. There's different ways you can give it. It can be IV, injectable, or intranasal. We're only going to talk about the intranasal because that's the only one that's really used anymore out in the field. It blocks the opioids. It takes the site that usually takes the opioids and blocks it so they don't attach. It only works for 30 to 90 minutes. And this is important, especially if you're with somebody who's overdosed and you've given them the Narcan. You have to be aware of that. It steals the parking space. So next slide, please. You can see this is just an illustration of how the Narcan goes in and blocks so the opioid cannot connect to the receptor. Next, please. So the Good Samaritan law, I'm sure most of you are aware of the Good Samaritan law, like for CPR and stuff like that. This one is a little bit different because it's designed to help people who might be questionable about calling 911. It offers some protection. I'm not going to read those to you. You can go ahead and read those, and I'll take a sip of water. But next slide, please. It does not offer protection for everything. So this is why some of the people really will not call. And you can read that and you can see why they wouldn't. So if somebody has real problems with the law, they're going to be hesitant and they may not want to call. Which is why I really push for them to do something rather than nothing and beat feet. Next, please. Now, if some night you can't sleep, these are the New York State penal laws as it relates to the Good Samaritan law. And I'm sure if you're in from some other state or someplace else, they have something like this as well. So look it up sometime. This just happens to be New York State's. Next, please. And that's the second part of it. Again, if you can't sleep sometime, look them up. And if you're from a different area, look up what yours are. Next, please. There is also a New York State public health law. This protects anybody, non-medical people from administering Narcan. Now, I get the question from people who are nurses or doctors or whatever else out in the field saying, well, I have to have a medical direction to do this. And no, you do not. And I always tell people, do you need someone to tell you to do CPR if you find somebody laying on the ground? And the answer is no. This is first aid, just like CPR is. So you can go ahead and do it. If you've been trained and you have the Narcan, administer it. It's first aid. It's not an unlawful practice because you're practicing first aid. If somebody fell down and skinned their knee and you put a Band-Aid on, you were doing first aid, same thing. This allows medical providers to do this as well. Next, please. I put this one in because this is an old picture from what they were originally administering, putting out there for people. There was very poor acceptance of this. So they weren't getting a lot of people willing to take the training other than people that had family members with a problem, with a substance use disorder that had overdosed before, so they could use it if they ever did it again. I always put this in as well, not that it's going to be any good at this point in time, but I tell people if you find vials someplace, because you got to remember I'm doing primarily training for law enforcement and EMS. If you see the vials, look for a needle. I don't want anybody getting a needle stick. Next slide, please. This is another system that they used to have. Primarily by this point in time, they've all expired. This one was a 2 milligram dose that you had to assemble. That little white tip on it was a nasal atomizer that you had to put the syringe together and put the nasal atomizer on it in order to use it. And because it was multi-stepped, some people forgot to put the nasal atomizer on, which made it pretty much ineffective. Next, please. This is the new nasal Narcan. Each dose is 4 milligrams, which is nice. It's doubling the dose that you can give in one shot. Now, The caveat to this one is you cannot test it. If you depress it, you've used it, and you don't want to ever test it. You're just going to take it and administer it. And we'll go into that in a few minutes. Next one, please. Love the nose. Most people have one. Even if there's damage to the nose, it'll still be absorbed. There's no pain associated with it. So if the person is semi-conscious, usually they're not too conscious, it's not going to hurt them. And you don't have to worry about a needle stick. And that's huge because you don't want to get a needle stick. Next, please. Now, this is the old one, but it still shows the way that the medication is dispersed across the nasal mucosa, which is a very rapid absorption for Narcan. And it still works the same way with the new one. Next, please. That is how you will hold the Narcan. Next, please. Next. So that's the box. Each box has 2 doses in it. Next, please. Signs of the overdose. We talked a little bit about this. They're going to be hard to wake up. They could be passed out entirely or really hard to arouse. The breathing can be slow or it can be gurgling sounds. And like I said, that's usually because they can't maintain their own airway. You're going to check to see if they respond. You're going to shout and shake them, just like you do for CPR. If you don't get a response, grind your knuckles into their chest, right in the middle, right there. If they still don't respond, call 911. My theory is if somebody is laying there and you can't shake them and wake them, don't care what's going on, you call 911. The quicker you get them rolling, the quicker they get there where you are. When you call 911, they are amazing on that end of the line. You're going to tell them, you can, if you're not comfortable saying they overdose because you've got nothing in the area to let you think that, you have somebody who's unresponsive and not breathing well. Okay? It doesn't make a difference. Get them rolling. If you think they've overdosed, make sure you tell them. If you've given them Narcan, make sure you tell them you've administered Narcan. If it worked, great. Tell them. If not, tell them that too. Next, please. If the person is not breathing, and this is here's my big push. This is my little pedestal I get on. If you're going to give Narcan, make sure you know how to do CPR. Narcan is not the cure-all for every reason that somebody is not breathing or unresponsive. So you need to know how to go to the next step. So if they're not breathing, you have to do rescue breathing for them. I am not a proponent for locking lips with somebody. That's why I want you to learn how to do CPR and learn how to use a barrier, pocket mask, or even the little barrier that comes in the Narcan bags, something to put something between you and that person. But it's really important that you do that. Next, please. So you start with 2 breaths if they're not breathing. You only breathe deep enough to raise that chest. Just when the chest starts coming up, you back off, don't keep blowing. And do a second one. If you can't get it in the first time, you're going to retilt the head and try it again because maybe you don't have the head tilted back far enough. Okay, and you'll keep breathing for them until help comes. Next, please. After you give the Narcan, when the person wakes up, we're being optimistic. Tell them what happened and tell them not to take any more drugs. Okay, it could cause another overdose. Narcan wears off in 30 to 90 minutes. Really important because if they do take more drugs and you leave them there, they're going to re-overdose because that's not going to last forever. It can be repeated in 2 to 3 minutes, and you'll see 2 to 3 minutes, 2 to 5 minutes. Don't care. After a couple minutes, if it's not working, give them the second dose. Just use the other nostril when you give it. When the ambulance gets there, make sure you tell them what you found, what you gave them, and their responses to it. If you have to leave, make sure you put them on their side. And I really stress this for people who do have to leave. But it's really important to really encourage the person to go to the hospital. It's where they're going to get their first introduction to help. I know in Genesee County, we have peers, which are people who have lived experience with substance use disorders. So they know how to talk and work with somebody who's in the same boat that they had been in. They help them and meet them where they're at. And I don't mean physically, I mean emotionally and everything else. Meet them where they're at to help them move forward if that's what they want to do. They don't force anybody to do anything, but they're there for them. And it's the first introduction. And this way they know if they do decide to do something that there is somebody there that will help them, because many people don't know what's out there for them. Next, please. When the person wakes up, make sure you lay them on their side after you tell them what's happened. If they're wide awake, that's fine. But if they're still kind of groggy, lay them on their side, because they won't aspirate if they start throwing up or if they're drooling heavily or anything like that. Next, please. There are some common side effects of Narcan administration. I'm going to be honest. If you're the one who's administering and you're not transporting or not in the hospital, chances are you won't see them. The reports that I used to get, I can honestly tell you the only thing anybody ever complained of on it was the nausea. They didn't get any of the rest of them. When it talks about lowering seizure threshold, what that means is Narcan can actually increase the number and length of seizures because it can block the effectiveness of their anticonvulsants. But bottom line is, if they're not breathing, who cares if they have the rest of the problems? Next, please. I keep going to push the arrow. And okay, like I said, we're not treating the drug. We're treating the symptoms. So if you have some situational awareness, if you go someplace and you see drug paraphernalia, then you're going to think that possibly there's something going on. So that's your situational. The hypoventilation, that's they're not breathing effectively, and respiratory depression, those are your big symptoms right there. Unresponsive or really out of it, and they're not breathing well. Those are what you're looking for somebody on an opioid overdose. Next, please. We don't care if it's a street drug or if it's a prescription drug. Little story, we had a woman in my fire district, elderly woman. She was end of life and she had fentanyl patches. And the family, loving, caring family, called. The mother was not real responsive. I get there and the daughter says she's on fentanyl. So she showed me where the patch that she had put on. I said, okay. So I took it off. And the other daughter comes, she goes, oh my gosh, I put her fentanyl patch on. So basically, the wonderful, loving family had double dosed the mom, who was a very frail elderly woman, given her too much fentanyl, and she wasn't breathing well. We reversed her. And the problem with this, if you have to reverse somebody who's on chronic pain medications, it can make it so they have irretractable pain that you can do nothing for until the Narcan wears off, which is 30 to 90 minutes. So that's the bad part on that. But at least mom started breathing again, and she was with us for another 6 months. And the family learned to mark things down after that so that they could keep better track of what they were doing. Next, please. So if somebody's on an opioid overdose, because there's a multitude of other things that can cause respiratory depression and altered level of consciousness, it's not going to hurt them. They'll get a wet nose. That's about it. So don't hesitate in giving the Narcan if you think it could be an overdose. Never hold back. Next, please. So quick review on this. It can happen slowly over to 1 to 3 hours, especially if it's a heroin or prescription medications. If it's the fentanyl or whatever, it's going to go a lot quicker. They're arousable, snoring, drooling initially, overdose, unresponsive, shallow breathing, gurgling, and goes downhill from there. Next, please. Now, in our area, we give them forms to fill out. And if they fill them out, I have them return them to JACASA, to Christine at JACASA, who, by the way, is changing jobs right now, but I'll get the new contact person for that. So they can have some data. Hopefully we get some data, but if they return a form, they get a replacement kit. So it's kind of like the carrot on the end of the stick. So that helps us get some more data as well. Next, please. Narcan, you have to store it at room temperature between 59 and 77 degrees. So essentially that means don't keep it in your car. Okay, if you keep Narcan in a car and it freezes, it's not going to be as effective. If it's too hot, it's not going to be as effective. It'll destroy it. So you want to make sure you keep it in a controlled environment. I know a lot of law enforcement has it. They carry it in their little jump bags that they carry when they go on duty. EMS has no problem keeping them maintained, but you have to be careful not to expose them to extreme heats and colds. Also protect it from light. That I think really was primarily when it was in the vials. The way they're packaged now, it's not a problem. But the other big important thing to remember is it does have an expiration date. So you want to keep an eye on that. When it expires, you can get replacements. Just keep an eye on that. So make sure it will be effective if you ever need it. Next, please. Now, I put this part in because, like I said, I deal a lot with law enforcement and EMS. You see that little patch of white powder there? That's enough fentanyl to kill you. Fentanyl is way cheaper than heroin. So the dealers started cutting the heroin with fentanyl because they were getting more money. I don't know why they wanted to do that, because they were killing off their users at a much higher rate. But anyways, next, please. The big important thing, and you guys may not have this problem as much as my EMS and fire and law enforcement. If you go into an area where you think there's been fentanyl, I tell them to wear masks, dust masks, face masks, some kind of a mask to keep any of the aerosolized stuff out of their lungs. You're going to wear gloves, but EMS and law enforcement are pretty good about wearing gloves. Safety glasses, because your eyes are a mucosal membrane as well, and that can be absorbed through your eyes. And it's really important, if your skin does touch it, you use soap and water. Do not use an alcohol-based agent. Use soap and water. And if you've been to a scene like that, get out of your uniform, because you don't know if you have it on your clothes. And the last thing in the world you want to do is go home, pick up your baby, love on that baby, lay him down for bed at night, and that baby doesn't wake up because you had fentanyl or something else on your clothing. Next, please. If you're familiar with the NCAP program, it's a wonderful program. It is still in effect. If you have health insurance, the NCAP program, you can go to a pharmacy and ask for Narcan. It'll cover up to $40 of your copay. It's got a standing order. The state, all pharmacies that do the NCAP program have a standing order for it. So you don't have to worry having a script from your provider. You can do this. I know there's been a few pharmacies that have given some grief, and it may not be because the pharmacy as much as your health insurance. But if that happens, and you know, health departments frequently have this, so I don't know about your areas, but frequently have Narcan. And if not, they may be able to put you in contact with somebody who does, so that you can get them that way too. Next, please. This is my contact information. If anybody has any questions after this series, feel free to contact me. I won't know your rules and regulations in your area, but you can find those out yourself. Usually, yeah, your health department's be able to help you. And if you have, we have JACASA and Spectrum in our areas that have a lot of information on anything you could possibly think of. And they all have peers. So you could always contact them to learn more information. The other thing we have in our area right now is the Perry program. And I'm not remembering exactly what it stands for, but it allows anybody to walk into, well, in our area, it's mostly police stations. We do have one city fire department. It has to be someplace that's manned 24/7. The city fire department in Batavia also does this. So if somebody comes into them and says, I have a substance use disorder, I need help, they will help them right away. So check your area to see if you have any place like that as well. It's a wonderful program. It's not heavily utilized, but when it is, it helps the person immensely, and they get help significantly quicker than other ways. Next, please. Okay, that concludes the PowerPoint. And I don't know if you guys have any questions, but I also have a video that Laura's going to put on for us so that you can see how to administer Narcan.
Narcan nasal spray is an emergency treatment for a known or suspected opioid overdose. The appropriate use of Narcan nasal spray can help you save a life. Narcan nasal spray is not a substitute for emergency medical care. As with any drug, you need to be aware of important safety information concerning its use. If you encounter someone who is unresponsive and you suspect an overdose, first shake their shoulders and shout their name.
Kevin.
Ask if he or she is okay.
Hey, can you hear me?
Check for signs of an overdose, unresponsive to touch or voice. Breathing is slow, uneven, or has stopped. Snoring, gasping, or gurgling sounds. Fingernails or lips are blue or purple. Administer Narcan nasal spray as quickly as possible if someone is unresponsive and an opioid overdose is suspected, even when in doubt, because prolonged respiratory depression may result in damage to the central nervous system or even death. Lay the person on their back to receive a dose of Narcan nasal spray. Remove Narcan nasal spray from the box. Peel back the tab with the circle to open it. Remove and review the printed quick start guide inside the package. Hold the Narcan nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Do not press the plunger to test or prime the device. If you do, you will waste all or part of the dose of medication. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the person's nose. Press the plunger firmly to give the full dose of Narcan nasal spray. Remove the device from the nostril after giving the dose. After you have given this medication, seek emergency help right away. Narcan nasal spray is not a substitute for emergency medical care.
I'm with somebody who stopped breathing. I think they've had an overdose.
Move the person on their side after giving Narcan nasal spray. If possible, put their hands under their head and bend their upper leg forward. This helps prevent the person from rolling onto their stomach. This is known as the recovery position. Continue to watch the person closely. If they do not wake up or respond to your voice or touch, or if they do not seem to be breathing normally within 2 to 3 minutes, use a new Narcan nasal spray to give an additional dose in the other nostril. Acute opiate withdrawal symptoms may occur from use of Narcan nasal spray in patients who are opioid dependent. Symptoms include body aches, diarrhea, increased heart rate or tachycardia, fever, runny nose, sneezing, goosebumps, also known as piloerection, sweating, yawning, nausea or vomiting, nervousness, restlessness or irritability, shivering or trembling, abdominal cramps, weakness, and increased blood pressure. When the emergency is over, put the Narcan nasal spray back in its box and throw it away in a place that is away from the reach of children.
Okay, that gives you there's a couple things about that film I don't like. First, no gloves. Second of all, she's got a cell phone. Call 911 right away, more quickly than what she did. Other than that, it just helps explain how to administer it and what you should be doing when you find somebody like that. Do we have time for questions, Laura?
Absolutely. So folks, start putting questions into the chat if you'd like, or feel free to unmute and ask a question. Bernie, I see your hand is up.
Yeah, I had 2 quick questions. One is about one of the things that opioids do is that, and barbiturates as well, tend to cause pinpoint pupils, really tiny pupils. And I wonder whether that is useful at all, or it's just too much going on for people to kind of attend to that. And
I stopped teaching that, and I'll tell you why.
Yeah.
Because if you're outside when you overdose, everybody's eyes are pinpoint. So I started just leaving that out and just saying symptoms respiratory is the primary symptom you're looking for. Did that help? And what was the other one? Sorry, I cut you
practical
off.
and helpful. The other question I had was in turning people on their sides, sometimes people will talk about preferentially using one side or the other, like the right side down tends to maybe empty the stomach a little bit more to the intestines rather than it sliding more easily up the esophagus. I mean, does that make any difference at all? And what do you think about it?
I'm going to be honest, it really doesn't. They'll tell you the primary side people put people on is the left.
Mhm.
But if you're in an ambulance, you put them on their left, because if you don't, they're facing the wall. So that's a lot of the reason they do that. But left side, the stomach is down then. So it's not apt to, I don't know. It doesn't encourage emptying. I mean, I don't think it has anything to do with that. A lot of people call it the left lateral recumbent position
Mhm.
as the recovery position.
Sounds like it's not important. So
Not
thanks a lot.
really.
Thanks very much, Bernie. And Jay asks, if it is necessary to administer a second dose, should the client be rolled over onto their back to administer and then returned to the recovery position?
You do not have to. As long as you can get to the nose, the nostril that you didn't put it in the first time, it's okay to leave them on their side, because it's going to aerosolize within the nasal mucosa, so it doesn't make a difference.
Great question.
Charlotte, I have a question. I have been attending these harm reduction meetings here at the Wyoming County Health Department, and I was told that Narcan is going to be available over the counter very soon, and these 45-minute formal trainings, unfortunately, are no longer going to be necessary because they could just read off the directions of a card. Do you see that coming down the pipeline, where unfortunately Narcan trainings like this aren't going to be offered because it's just available?
I think they'll still be offered in some places, but right now, if you were to get the Narcan in the boxes you get, the instructions are there. It's not a problem. The video you showed, it's on YouTube, so it's not a problem. The biggest question, I know, like EMS and fire and law enforcement, they like the in-person trainings because, well, first of all, EMTs get CME for it, so they get an hour of credit for education. But I think it's important for some people who want the one-on-one, and you don't get the data. I'm a data geek. I love data. I like to know how it's impacting our region. So that's one of the biggest things. But it could very well, and I'm going to tell you right now, a lot of places they're doing one-on-ones with them and they're not doing this kind of training. If you go to a farmer's market and they're handing out Narcan, you're not getting this training. You're getting the down and dirty with the card information. So do I think that's going to happen? Absolutely. Do I think it's advantageous? For some, absolutely. It's not a big deal. Administering Narcan is not a big deal. It's recognizing the signs and symptoms more than just the mechanical how to do it. That's the important part that you're not going to get from the card.
Agree. Thanks, Charlotte.
You're welcome.
Okay, and we have another question from Tia. I have heard that some individuals can be upset, aggressive when the Narcan kicks in because you ruined their high. And have you seen that in any cases? And then what would you do in that situation?
Personally, I have never seen that. Usually they wake up and they're kind of groggy initially. I have had reports, really limited reports, like 1 or 2 out of 1,600, that said they woke up combative. And it's not always because you ruined their high. Here's what I want to tell you. These people are hypoxic. People who are hypoxic and you wake them up quickly still don't have the oxygen they need going to their brain. So they're confused and they're agitated. The same thing happens with diabetics when you reverse them. But it's not always because you've taken their high away. It's because they're still hypoxic. And I'll tell you a little secret that I tell EMTs. Before you give them the Narcan, if they're not breathing well, do what you used to do before you had Narcan, bag them. So you take the Bay valve mask and you ventilate them for a few minutes to get that oxygen level built back up. And then when you reverse them, the hypoxic problems are not going to be there.
Great question. Thank you. Any other questions from folks today? I love that everyone has stayed on and stayed engaged. Actually, let me shut off the recording. Hang on.